Hi everyone, my name is Kristof Gutowski. I'm a fourth year medical student from Kansas City University at the University of Wisconsin this month with the Division of Plastic Surgery, learning from the best Dr. Zhang today, so I'm extremely excited to get started.
Yeah, hi everyone. Yeah, here's University of Wisconsin. Today we have Kristof. So we just talk about a microscope, and if you are interested about a microscope, there's some other videos you can see how we talk about the microscope step by step. And now we're moving forward to under the microscope. Yeah. What's this? The microphone is here.
Right there, got it.
Okay, now let's set up a microscope, and now for the rough focus. So here at the beginning, we want the microscope, here's the focus.
Okay.
We want it in the neutral position, so we can go up and down. Instead of it's already all the way at the bottom, and then we cannot go down anymore. That's not good, right? We want to run the microscope still can go up and down during the surgery.
Gotcha. And that's how the pedal here, if we were to click it, focuses into the middle.
Yeah, at the beginning, like the microscope in the OR, there's an indicator, like you can see it in the middle a lot. If there's no indicator, my way to set it up is like I press the focus going down all the way, and then press it going up like 1, 2, 3, and then I start counting 1, 2, 3, 4, 5, 6, and then I press it go back 1, 2, 3. So 3 and 6 is kind of in the middle.
Got it.
Some of the microscope, there's an indicator in here. There's two red spots. You can see if it's focused in the right. There are two laser spots you merge to one.
Interesting. Okay.
Yeah, you will see that. Okay. Now we just wait for a rough focus. Okay. See. Can you see clear now?
Yes, I can see clearly.
Okay, you move the microscope. Yeah.
Just gonna raise it up a tiny bit more so I'm not.
Yeah. Okay. The thing about this is just a toy. Okay.
Yeah.
My RC car. Now you can see clear. Okay. Now you step on the focus and adjust a little bit.
Okay. Here's more focus. Yes.
Yeah. Right. Oh. Yeah. You can step and try. No matter mess up. I want you to kind of mess up and make it clear again. That's the learning process. Okay.
Yep.
Now it's perfect.
Now it's perfect. Yes.
Okay. So we want perfect. We don't want, oh, it's okay, because if it's okay, in order to see clear, the muscle in our eye, they need to compensate that to make a sharp imaging to our brain. That's the fatigue from.
So you have it as clear as possible. If it's not, you're gonna fatigue more.
We need to our eye muscle. They will like to come. They need to work hard to compensate that and make a clear imaging. So just let the microscope do their job instead
of us.
Yeah. So we need the perfect imaging. Now it's good. Okay. Now I want you to. No. Your paper. Okay, now what is the magnification here?
0.7.
Okay, go to 4. Step zoom. I show you how to step. Yeah.
0.4 or 4?
Like this on your side.
Yes.
Use your heel. That's easier. On the other side, use your toe.
We go down. Okay.
Yeah.
I'm gonna go down to 0.4.
Yeah, go down to 0.4.
All right, and we're on 0.4.
Yeah. So now we can see what's the diameter of the field we can see?
I can see actually 5 centimeters right now.
Yeah,
It's wider.
yeah.
Maybe six. Yeah, about 5.5.
Okay, yeah. Oh, write down 4 times. Right here is 0.4.
Yes.
Oh, yeah, and here. Yeah,
And
10. So now the magnification is 0.4 multiplied by 10.
so 4.
So it's 4. Yeah. And then the diameter of the view is like 6. You don't have to be very accurate. It's just kind of,
Just to know, I have an idea.
yeah, yeah. So, okay, let's zoom in the microscope all the way.
Oh, high does this soon go? Oh, 2 point. Okay, 2.4.
Okay, now take a look at the
Maybe maybe
forgot.
2 centimeters in there.
Yeah. Go back to the zoom in. Go back to the plot. I forgot the depth. Having the depth. Now it's 4. So the depth. Take a look how how many centimeter we can see clear.
5 centimeters.
Yeah, I find here it's already blurred.
Yeah.
So actually, like it's kind of big from here. It's kind of it's almost up to here, 1.5, and then starting getting blurred. So that's the depth. It's kind of like 1.5.
So here, I can see 3.
3.
3, yeah.
Okay, yeah, okay. Write down 3. Yeah. So that's the depth and the diameter of the field.
Okay.
At 4 times.
Yeah. So at 4 times we get
Yeah, okay.
6 for the
Yeah.
for the diameter, 3 for depth.
Yeah. Okay. Now let's zoom in the microscope. Okay. Now you lose focus. Okay. Now try to, because now it's our focus a lot. Let's move. You move the microscope a little bit and adjust to a lot focus. Yeah, okay. Now use the foot control because the hand is hard to adjust very, very accurately.
Wow, we are very, very zoomed in.
Yeah, very zoomed in. Okay, now what is the diameter?
I do not see a full
Like this is one space is kind of 1 millimeter, so it's on my side it's almost like 1 centimeter.
Yeah, maybe just under 1 centimeter.
Yeah, okay, right down. Now it's 24 times.
Yeah, 24 times.
Yeah. You take a look at the depth. How many millimeter you can see here?
2, maybe 2 millimeters.
Yeah. Okay, now zoom out the microscope again. Yeah, and then zoom in the microscope one more time. Zoom in. Just zoom in all the way.
Zoom in all the way. Oh yeah, there we go, going in.
Okay,
Yep.
Chris. Now this time, when we zoom in and zoom out, the microscope stay in focus.
Oh yes,
Right?
it does.
At the beginning, when we zoom in and then it lose focus.
So it has some memory of the focus here as we're going in at the same time.
Yeah. So in the during the surgery, we want a microscope stay in focus. No matter we change the magnification, right? That's convenient. That's the turn of the microscope. That's the parfocal. Parfocal. Yeah, but normally it's just kind of, we don't have to adjust the focus anytime, whatever when we want to go. Like for the finger implantation, we may go 6 on the artery, maybe go to 10 for the vein, and go to 8 on the nerve. So during the surgery, we may adjust the focus of the zoom, the magnification. But like as we zoom in, we don't want the microscope to lose focus.
Of course.
Yeah. So this part I want to talk about is the depth. Like the reason it happened like this way is like at the beginning, we can see clear at 4 times, right? At that time, the depth is like 3 centimeters, 4 times. So when we can see clear, that means this ruler is within here, or here. We can see clear.
Yeah.
Right. And then at 24 times, the depth becomes 2 millimeters. So that's why when we zoom in all the way to 24 times, if the ruler is in here, our focus. Only very lucky, the ruler is in here, we can stay focused. But 99% we won't get that lucky. And then when we go to the 24 times, and we set up the microscope, and then we can see the ruler clear. That means the ruler is in here. And then we zoom out the microscope to the lower power. Lower power has a larger depth. The larger depth will definitely including this small depth inside. That's why after we focus the microscope in higher power, we zoom in and zoom out.
Because you're already down there. It knows you're already lined up rather than trying to work down.
Yeah. So this is the depth and how we can use the depth to set up a microscope. Yeah. So when you go to the OR, now you know.
Now I know.
Yeah.
Always start.
Yeah.
Once you're zoomed in, focus from there, and it'll be good.
Yeah. We may not have to go to like the Zeiss microscope in OR. You can zoom into 30 times. But if you just go for EIP, you may not have to go all the way to 30 to set it up. You may go to like 16 or something, and then set it up, and then go out to the appropriate power. You can, you feel it's good for the surgery. Like maybe you want 6 on doing the artery, and then you want to use 4 to do the vein. So 4, 6, when you set up in 16, you can stay in focus at that time, at that magnification.
Yeah.
Yeah. So that's the depth. Okay, let's zoom out the microscope. Now I want to talk about the instruments.
Okay.
Now the instrument, there's only 4 instruments there. You can see there's a lot of instruments. All kinds of different things. So like there's only 4. One is the needle holder, one is the scissor, one is the forceps, and the other one is the dilator. Mostly you have these 4 instruments. That's good for one set of doing any kind of instrument, any kind of microsurgery. The difference is the material, the shape, and the size of the tip. The size of the tip is most important. Most of the money is paid for the tip. Once we lose the tip, then we lose the money. Like here, you can see so this is all needle holder.
All needle holders.
Yeah,
here.
all needle holders.
And in the demonstration videos, you recommend having it sloped like in this direction rather than like this is a little bit easier when you're.
Yeah, pick up the needle. We usually most of the time doing stitching, we hold them like this.
Like this, yeah.
When we pick up the suture, we sometimes flip it. Like this one is kind of, the curve can bypass the vessel, so we can go deeper. If we hold it like this way, if there's a vessel in front of us, before we go that way, this curve already hit on the vessel. So sometimes we pick up a suture bed easier by this holding this way. It's not always have to hold it in some special way. Just depends on the situation. So like this 4 instrument, what is the difference you see?
I see. For this, I assume it can lock into place when you.
So this lock. Yeah.
These two, I don't think can lock. It looks to be it can prevent some resistance, but not fully lock. These two are lacking.
Yeah.
That mechanism.
Yeah. So that's the lock. This is without lock. So you can look at under microscope, see how it locks.
See the mechanism for it.
Yeah, see that? That's a hook.
Yeah.
Yeah, when we reach the hook and then it locks. When we press it again, it beyond the hook.
Are these the most commonly used in the operating room then with the locking mechanism, or
depends?
Depends.
That's you will try and then you will understand better. The locking instrument, the problem is once it lock, you have to unlock it. It's not so freely. Like this one is just freely. You can put down a needle, pick up a needle.
Very go quicker.
Yeah. But the locking instrument, like sometimes you pick up a needle and then you can put it there. The needle won't go away, like the regular instrument. And what other difference you see?
I mean, in terms of texture for the outside, or how you're holding it, I'm not sure if the color also has maybe other indications, but I noticed that as well. These look to be a little longer than here. Definitely broader tips, a broader tip with the one in the middle.
Yeah, the tip, good point. The tip is important part. This tip stronger, and this tip is thinner and more delicate. So the rainbow, this instrument is designed for the super microsurgery, pick up like a 11 nose needle. This stronger needle holder is for the regular standard surgery. We pick up a 9080. So if we pick up the big needle by this very fine instrument, it will damage the tip of the instrument. So what's other difference? Yeah, the color is also
the color. Yes.
The color like this is the titanium instrument. This is stainless steel. The difference of that is the titanium instrument won't got magnetized. Once it got, every metal we got magnetized because on the earth or if the OR they use some magnet things. And then it got magnetized. Once it got magnetized, it's annoying because the needle is always kind of attached to it.
Attached to the.
Yeah, it's making it hard to use.
So you want these demagnetized stuff.
Yeah, and then we have to demagnetize. So this is the.
That's the tool for it.
Yeah. But it's hard because it generates a lot of heat. I bring this one to Dr. Paul's office, and the nurse from the OR take this one out, and then I bring 30 instruments to want to demagnetize them. But actually after I demagnetize 3 or 4 of them, it stopped working. And then I have to cool it down.
Cool it off.
Crazy. So another thing is this is the flat handle. The handle is flat.
Oh, flat versus the more
this is the round handle. So that's the difference. Round handle, one of the advantages, you can turn it easier. Flat handle, it's more, you can hold it like more stable. It's not so easy to kind of slip away from your hand. Dr. Paul, he likes the flat handle, and he retire the round handle instrument with the lap. The round handle, I like the round handle a little bit more because at the beginning, I thought it's the personal preference, but later I realized it's because of the different surgery we do. My daughter boy did a lot of DIP. DIP is a big piece of fat tissue.
Yeah.
And then after handling the flap a lot, the glove become very slippery.
So you want as much control.
Yeah, it's still holding a wrong handle instrument, sometimes it's hard to control. And for me, I was a hand surgeon, so our hand is not so, usually it's sporadic glove. So as we got the benefit from like turning it easier, and then I personally I like the wrong handle a little bit more when I do in hand. But if I handling a flap, maybe I would like to I prefer the flat handle to get the benefit of the flat handle, stay more stable, easier to control. Yeah, and then here you can see this is a needle holder and scissor combined.
Okay, so that's the more distal portion, holding or proximal cutting.
Yeah. So this is something special I order for animal surgery, because like usually doing microsurgery we will have a assistant, but when I was doing a kidney transplant for lab, I don't have the microscope, only allow one people because it's facing on to the table on the wall, and the protocol require we have to finish it. But it's give me a time 30 minutes. That means I take it out from the ice and I need to finish the anastomosis heart rate and weight within 30 minutes. And it's really hard. Even I'm pretty good, most of the time I still kind of at 35, 34 minutes. And because every time after I put a stitch there and then I put it down and then I pick up a needle and then I cut it and then put down the needle scissor and then pick up a needle holder, pick up the needle again.
It takes time.
Yeah, because nobody can help me to cut the suture. And then I know there's an instrument like this, and then I order one, save me like 4 or 5 minutes, so I can kind of get the kidney transplant done like 28
under the ischemia time.
Yeah. And then the setup is also important. You need to set it up very, very good so you can go directly to the anastomosis. Don't have to spend time to kind of manipulate the needle or the kidney or something. Yeah, so setup is really worth to spend enough time to be efficient. Doing microsurgery, the fast is not you stitching it fast. That's not, because you're doing the stitching fast, there will be higher risk of making error or making mistake. The fast is being efficient. You remove all the wasting step. That's the way of being fast in the microsurgery. Stitching, doing things in the right way every time, every stitch, to avoid a problem, to avoid a flap take back. That's the way of fast.
Of course, yeah.
Yeah. So sometimes I see the resident, they try to do it fast. I always tell them, slow is fast. And it's worth to, like in the flap, setting the vessel and doing the anastomosis. These two parts worth to spend enough time to enjoy it. That's your life.
Yeah.
Being a microsurgeon, that's your life. If that's your life, you don't want any minute go fast.
Especially at minimizing any delayed complications. Just keep it as streamlined. Get it done the right way the first time.
Yeah. Be efficient. That's the way to be fast. Okay, now I will told you guys the regular set. This is the regular pen instrument in the in the plastic surgery. Regular means one thing. The tip is 0.3 millimeter. 0.3 millimeter. Like this one is the. So here's a number.
Is that 0.1 millimeter? Or
yeah, 0.1. Yeah. So this is the company, EM. So it's the round handle, curved needle holder, 0.1. That's the size of the tip.
Yep.
Yeah. And this is S&T is the company. C is the curved needle holder. 14, this 14 is the length of the instruments, 14 centimeter.
14 centimeter.
14 centimeter. This one is 16.
Oh, yeah, it's a little longer.
Yeah, in the cardiovascular surgery, they have like 18. Yeah, sometimes it may be longer, like 24.
Oh my gosh, that would be very difficult too.
Yeah, but their hip is way bigger than this. Different instrument. Because sometimes they have to reach to the chest cavity to a micro. Okay, so
yep.
That's now this one is also 0.3. You can see it's very close tip size.
Very close size, yes.
Yeah. But this one should be 0.4. You can see it.
Oh, just slightly, yeah.
Yeah. So when it's microsurgery, when we go and set is a standard one, that's 0.3.
Standard for plastics 0.3.
Yeah. The Caesar. This Caesar. Put some Caesar, the autoclave for pig limb transplant. So, but here we can see by the same thing, handle. It's flat handle, round handle, and the length. This one probably is 14 centimeter long. This one is 16. Size of the blade, right? This. Yeah. So this one is from the tip of the scissor to here is 2 centimeter. So this one is the standard PRS instrument. This one is a little bit smaller. It's 1.5. Okay, that's for hand surgery. Most of the time, you think about like that. Design and curved scissor and the straight scissor. There's a special name. Let's take a look at here. Now this is a curved scissor. I'll show you how to read this number. ASSI is a company, right? So SDC 18RA. That's all information about the scissor. Scissor, this S is scissor. This D is dissection. This C is curve. So the scissor, curved scissor is a dissection scissor. So you can see most of them, even the regular scissor, we use the curved scissor to dissect something out instead of use a straight scissor. Straight scissor, most of the time we want to make it like a straight cut a suture or something. That's the straight scissor. And here is the 18 centimeter long, and this is R is the round handle. Round handle. And this A is the diameter of the round handle.
The handle itself.
A millimeter. So there's a global standard. Most of the round handle instrument they make it A millimeter. And in the ophthalmic surgery, their instruments sometimes even smaller, like maybe 0.7 or 7 millimeter or 6 millimeter, a little bit smaller.
Wow.
But for most of the hand plastic or even the neurosurgery, the round handle instrument usually is 8 millimeter. So that's the information of that. This is the
S&T for the company.
Yeah. So this is scissor. This A is adventitia. This is the straight. Remember that scissor D SDC on the curve, like this one. Curve is the C is the curve. So this S is the straight. So adventitia straight scissor and 15 centimeter long. So when they talk about adventitia, it's kind of if you go to read a book of the microsurgery, the first step is to clean the adventitia to prevent it going to the lumen. So in the textbook, it kind of you pick up the whole adventitia and then make a straight cut.
Sure.
And I think that might be the reason they name a straight scissor as an adventitia scissor. But actually, this is too good to be true. Most of the adventitia cannot pull like that way. Only if that happens, that means there's already damage of the vessel. So the adventitia already decluttered from the vessel. So most of the time, when we working on the adventitia, we holding the vessel, and then from the side here pulling the adventitia a little bit, and then we dissect the adventitia a little bit, and then cut it to clean the adventitia about like 2-3 millimeters away from the edging, so we prevent it going to the lumen. The reason we clean the adventitia is because the adventitia is the tissue from outside. Sometimes when it gets into the lumen, the blood cell, you consider that's something from outside. Kind of think about, oh, I see the tissue from outside. That's a hole.
Yeah.
So the fibrinogen and the platelet will go attach it to fix it. But that's the way of making a thrombosis.
Of course, yeah, anything goes in there.
Yeah, so
thrombosis.
Yeah, so that's why we clean the adventitia. But actually, clean the adventitia, we use a curved scissor. But the name of the straight scissor, they name it adventitia scissor. So most of the time, we use the adventitia straight scissor just to make a straight cut or make a spatula cut to make it a straight edge to prepare the end of the vessel for anastomosis. Yeah.
Wow.
So that's the scissor. Not much difference. We have when it going to very small. This is not a superfied. We have a superfied scissor. Looks nice. Yeah, but we can read the information here. This is what's the S?
So S scissor, D
dissection.
The dissection, and then curve.
Yeah.
What's it? 15 for the length, in centimeters. R round.
Yeah.
And then 8 is the diameter of the round.
Yeah. So this F and 12, that's a little bit new. We didn't see it in the other instrument. So this F is the 5 blade. So that means the blade is even smaller for super microsurgery. And 12 is the length of the blade is 12 millimeters. From the tip up to here.
Okay,
from
so
the tip
5.
to the joint. But this one is there's some of the needle holder it's even smaller than this one for the super microsurgery. Nothing about it. It's a tiny vessel. If we still use the scissor like this one, it's hard to dissect it out.
It can still yeah.
Yeah. So like when we go to the LVA, lymphedema surgery, and then we have to use the super fine instrument like the rainbow instrument.
So typically the rainbow instruments, are reserved for the microsurgery kits, doing LVA, more lymphatic.
Now it's the rainbow instrument is the standard set for the super microsurgery. Okay, now and then we go to the instrument. So this is the forceps.
Little curve forceps, yep.
Yeah. So the forceps. Let's see. We get a long handle first. So you can see that.
Wow, that's a lot.
Yeah, so this is the standard tip. I mean, standard is 0.3. Even here you can see even there's a 3 there.
Yep.
3 is the diameter of 3.3 millimeter. And
Now, are the curved tips preferred though compared to a straight tip?
for different purpose, like this is
The angulate area.
yeah, this is S&T through the forceps, angle, and long 3. So that's angle forceps is when we pass something under the vessel and something is helpful.
Oh, okay, yeah.
Yeah, the straight forceps is easier to use when we're doing the dissection or something. And this round handle, the same, it can kind of turn a little bit easier. So like sometimes we pick up the suture is not in this direction. The suture is on this direction, and then we need to turn and then catch it easier. Because if we use an instrument like this, then we have to turn our hand a little bit to pick it up.
It's more challenging that way.
Yeah. So this rainbow forceps is you can see the number from here. 0.03 or 0.05. So this is now is the smallest needle of forceps we can use. We have in the OR. You can see it's well designed. See, like this forceps is pretty much just straight, right? This one you can see it's like the clamp of the
highest quality.
Yeah, the crab.
Crab claw. Yes, yeah.
See that? So this one can pick up very fine structure very good. It's designed based on the require of the super microsurgery father for the Kushima. So it's kind of designed by super microsurgeon. So it works very well.
Was he over at Chang'an Hospital or was he at a different one?
Oh, he's now moved to another hospital. He was the Tokyo University chair of the plastic surgery. Yeah, he is the pioneer of the super microsurgery. He designed the DIP 1989.
I didn't realize that it was 1989.
Yeah, 1989. He is the first one to use the DIP. You may not want at that time, right?
But now it's so commonplace, yeah.
Yeah, I was 9 years old at that time.
So okay, I see what you mean compared to the very fine point with the super microsurgery forceps.
Yeah. So this is the ASI lateral forceps, through the forceps. Through the forceps is because when we have microsurgery, when we do microsurgery, we don't have any instrument. So we just follow the instrument from the Tura store company.
Oh, really? That's the history behind it?
Yeah. So this 5 is the 5-inch. Yeah, 5-inch of this forceps.
Yeah.
Okay, now take a look at what's the difference of these two.
It's the slope that it's coming at. This is a straight shot. This is here. It's coming at not a true angle for the tip, but it's starting at some degree of angulation. Yeah,
and take a look at the tip. Yeah.
Oh, it really narrows down at the most distal portion and meets together.
Yeah. So like this one, you may see this one is only the tip can touch. This one can touch the segment of the tip.
Yes.
Right?
Yeah.
So and also you can see here is pretty smooth, sliding. So this is the dilator.
That's okay. Oh, for the buses,
Yeah. So dilator, we use the dilator is when we dissect the vessel out, we cut it, and when we irrigate it, and it's exposed to the room temperature. The muscle, smooth muscle, we tending to close it, expansion. That's expansion. So before we do anesmosis, we used to put a dilator there to make it go back to the normal size. Or if there's preference, we may dilate the smaller one to match the bigger size. So that's why we use the dilator, and that's why we want it smooth, because we put into the lumen. We don't want a sharp instrument go into the lumen. So if for any reason, if not necessary, don't put a so sharp instrument to the lumen of the vessel, because the internal is the best way to prevent the thrombosis. And Usually there's an angle right here, so we can put in the lumen easier. And most of the time we use the dilator to when we're doing stitching. Think about like if we use this forceps to pick up a suture, we have to really pick up the suture like here.
Yeah, very, very minimal.
Yeah, but here we can catch the suture, whatever, from here to here, we can catch it. So it's, you may see the teacher, they use a dilator doing the anastomosis. Yeah. Okay, that's mostly for the instrument. Sometimes you may see something different. It's like the coupler. You may see a joystick forceps.
Actually, for the venous anastomosis, where to put that down, the coupler down, and use the hockey stick to.
Yeah, hockey stick. And sometimes you may see that this is all straight or needle holder, a flat needle holder, handle forceps, one handle forceps. And sometimes you may see a forceps to handling the clamp, so you can hold the clamp. See that. Sometimes you see it looks like it's the regular forceps.
Oh, but to clamp down the vessels when you're actually doing the anastomosis.
No, it's kind of holding here. Like look at here. There's you can see there's a groove here.
Yes.
So some of the forceps to handling the clamp, they have a groove can match the groove here, so they can holding it easier, handling the clamp.
Rather than sliding off with a normal forceps.
Yeah. And here, this is also a forceps to handling the big vessel. I see this forceps is designed as a traumatic forceps handling the vessels.
Yeah.
You see that? So this bumpy thing is designed to kind of mismatch each other.
So it goes in like a V shape.
Yeah, and then it's smooth, and then kind of reduce the trauma to the vessel. But this one is handling the big vessel.
It's like the distal portion of a right tooth force stuff how it comes together.
Yeah.
Is there any writing in there for the manufacturer, the size?
I think it's the name maybe the Coleman forceps. There's a lot of different names.
So many, yes.
Yeah. So this is the instrument. And then let's talk about take a look at the suture. So the suture, at the beginning, I thought, okay, suture, good, just, okay, Nio, we told the nurse, okay, give me a Nio suture. But actually, when I come to the lab and then work on more different company, I realized there's different things. So in the plastic surgery, we use AO, okay, write down, AO, 9O, 10O, 11O, yeah, and then 12O. 12O is the smallest suture we have in the US.
And do you use both 11 and 12O for microsurgery, or typically just 12O for microsurgery, or for super microsurgery?
It depends on the size of the vessels we use. Like from the 9AO, usually I would like to use it on like the 3 millimeter back. And 9O, I would like to use it on 2 to 3. And this one is 1 to 2, I would like to use 10O. Below 1 millimeter, I use 10, 11O. When it going to like half millimeter, That's super microsurgery. If I have 12, I would like to use 12.
So really reserved for survival purposes, yeah, before below half a millimeter.
Yeah. So this O, this 990 something is the suture. I take a look up here. It's the 90, 90, 90, AO, 10. Correct this one, I feel very interesting.
11. Do we have a 12 in there at all, or just still up to 11?
12, yeah. So 0.4 metric, 0.3 metric. This now is 4.3, 0.1, 0.2 metric is the 10 O. 11 O is 0.1 metric. Let's take a. So this is the 12 O.
0.01.
Yeah. This is the 0.01 metric. Metric is a pharmacology unit. It's hard to relate to the inches. Maybe it's kind of like one of 1,000 inch of like that.
But we get smaller as we go to the 12.
Larger number, it goes to smaller. So like the 10, 11 O, this one is 10 times smaller than that. So that's the suture.
So we're saying if we go from 10 to 11, it is half as small, but then the jump from 11 to 12, this a tenth the size.
Yeah.
11.
Yeah, I don't know how they made this suture so small. And then the company, in a meeting I talked to the company, they said they handmade this needle and suture. They use laser to put a hole on the needle, and then they insert the suture inside the hole, and then the machine squeeze a little bit and then catch the suture.
Now for 12 though, can you see these unassisted with your naked eye, or do you have to be under a scope to see these?
You have to under a microscope. It's really hard to see the sutures. So that's the suture. Okay, let's talk about the needle. Needle is even more important. So let's take a look at this is very common use of BV, that's the blood vessel. 100 micron, that's the diameter of the needle, the body. And 4 is the category of the needle. And 5.1 millimeter, that's the length of the needle. 3/8 circumference. We don't like the half circumference needle. Sometimes we can see like in the tendon repair that bowling, we may see the half circumference of the needle. Microsurgery, we like the half circumference of 2/3 or 3/8.
Because you just go more horizontal with your bite rather than perpendicular down.
Yeah, we don't have to turn so far. Okay, now this is one of the needle. Take a look at this needle. VS maybe is the vascular or something. So take a look at this needle. This needle is taper straight. Taper straight is considered as atraumatic. This needle is the spatula needle.
I don't think I've only seen the taper and cutting. Never the.
Yeah, it's crazy, right? I don't know until I see this one. So, but actually, like this needle should not use on the vessel, because once you make a hole like that, the suture cannot block the hole, right?
That's why you need the taper instead.
Yeah. So and then slowly I realized the company just randomly makes their instrument, makes their whatever they have to make their product. This may not a right product, right? It's crazy. And here, I would like to use this as an example, like this one. The 10O is this one is 3.8 millimeter. The rest the side length, and the diameter is 130 micron. That's 10O. The needle is bigger than
That's
the
interesting.
9O.
Yeah.
We should go to a smaller vessel. Why we use a bigger needle on this smaller suture, right? So they make a big sense. And then the 10, 11 is 50 micron. That's half size of the 90, and that's 3.8 milliliter. That's good because we want to shorten smaller vessel in a need smaller instrument vessels. And then let's go back to this AO. I take a look at this AO. AO, we work on a 3 milliliter vessel, big vessel, but this needle is 5.5 milliliter long and 130 micron. That should be a good size, right? But this product is 3.8 milliliter. The needle is really short.
Just like the 11.
Yeah, yeah.
So what would be the purpose if you're using the AO? Why would you
make it so small?
Yeah,
so short needle.
We don't know.
You like I use this one because we have a stem cell lab. They generate a synthetic vessel and transplant to the femoral artery on the monkey. And then they told us, what suture do you like? I said, oh, AO. And then they bought an AO. And then when we start doing microsurgery, that's the AO we have at the time. It's really hard because the vessel is thick, and then we stitch, and then it's buried. We can, the needle holder occupy like 1 milliliter, and there's only one, a little bit long.
You have 2 more to work with.
Yeah, it's really hard to take it out, and it's impossible to use one step to reach both sides. So I told them to no, that's not. We need to buy another thing and donate this one to our lab for training. That's why we have this product. Yeah, so when you are the first person in the hospital, you need to understand when the nurse told you, okay, Chris, what suture do you like? You cannot just tell them AO suture.
You have to be specific with everything.
Yeah, or you will kind of suffer for a while, and then you realize there's something different.
Because I was under, of course, probably the impression that if it's for us a 4.0 versus 5.0 fast cut versus everything, rather than looking truly at each side. I think 3/8 versus half.
Yeah, like this is the brow vessel, but the diameter is 170 micron, and the needle, the suture is, you can see the suture is 60 centimeter. So this suture is too long for our hand and plastic surgery.
Okay, so you'd be pulling out.
Yeah, they use this one for the transplant or the cardiovascular surgery. When you go to the cardiovascular surgery, they tie nuts by hand.
They needling.
Yeah, and then they run both ways. They like a big vessel, like 2 centimeter vessel, they run on this way up and this way up, and then they tie up. Their vessel is centimeter.
Which
our vessel is milliliter.
Yes.
So that's the difference. And you can see, this is 0.4. This is Europe. pH is Europe unit, but it's the same of the metric. Like this 0.4 pH is the 0.4 metric. Same.
Oh, same metric. Yeah, same version.
Yeah. So here you may see a special needle.
Oh, that's the same one that we had. Right.
Yeah, similar to this one, but even crazier. So this one, see, it's for our stomach.
Oh, yeah.
Yeah, I have no idea at the beginning, and then until I asked a friend. He said we stitch on the eye when they're doing eye surgery. The eye tissue is really stiff. It's not like a vessel. It's easier to pierce. The eye tissue is really hard. You need to hold it very well, and then stitch it. That's why they want a flat body. And another thing is they want to take a partial bite of the eye. They don't want to pierce the full thickness of the eye like we do on a vessel.
Yeah.
Because once we do a full thickness pierce, the body, there's liquid inside the eye. It will leak out. And also there's a high risk of the bacteria enter the eye to cause infection. So this spatula needle is easier to take partial bite. That's why in ophthalmic they use this kind of needle.
Yeah.
So that's I think that's a good way, and don't put it on a vessel for needle for the microsurgery and.
I think that's one of the biggest takeaways, to make sure you're not using the spatula for any plastic surgery or microsurgery. Reserve it for our colleagues.
Yeah. So like this is the 12 smaller. You know the needle is 2 Newton. Like this 11 is exactly like this size. This 12 is, the needle is like this one. So the size is 50 micron, the same of this 11 needle. It's really hard to see. This is suture. I think
we see the suture. That's about it.
This is the nylon suture.
Oh, this is so much larger compared to.
Yeah, this is the 5.1 needle. I think we use up the 12. Let's go get it. This is the original from the 12 from here.
Wow, even under the microscope, it's very small.
Let's see, this is the. Now you know this is 5.1, twice of the.
Oh yeah, you can't, like, visually, not looking through the microscope, you're unable to see it.
Yeah.
The needle.
Yeah. Yeah, finally I got most of the package.
All the packages that exist.
Yeah. I can take 1 hour. This one thing I'm gonna start here. This is the 2 millimeter needle. This is the 5 millimeter, 5.1.
Oh yeah, the 5.1 is a lot larger.
15 micron. It's exactly like 2 millimeter. Here's a ruler. One space is 1 millimeter. You can see it's. Oh, actually, this may be the 3.8 at the 12, the 11 no. Yeah, because it looks like it's longer than 2 millimeter. Let's take out one of this. Oh yeah, this one is this.
About 2, yeah. Or just over 2.
Yeah, just. Oh, I think the 2 here is the core.
Oh, yes, yeah.
Yeah, 2 millimeter. So this may be the.
So it might be a larger size then.
Yeah, this may be the 3.8 core that needed. Okay, now I will let you try to pick it up.
What? So I'm right-handed. I'm gonna hold my guard with the right hand, and I think for the intro video you recommended grabbing by the suture first and then loading with, rather than suture to suture or needle to needle.
Yeah, hold the needle dangling the suture.
here I have it up. And if I want to adjust it, also I use the suture itself.
Yeah, good. Yeah, nice. You can pick it up. Good. Did you practice handling the suture before?
Not under there was the only experience I had for microsurgery during the trip to Egypt. For about 15 minutes, I went under the microscope. But that was my first time suturing ever.
Oh, yeah. Try this smallest needle in the U.S. and you use the finest instrument also.
Let's see if I.
The needle holder in your hand is $1,500.
Wow, and it's super microsurgery, correct? Yeah.
Yeah. So keep low, don't raise it because
okay.
the must be out of the you cannot see through.
There we go.
Yeah, good.
Oh, so you also want to use your background a little bit to support rather than just holding it in midair.
Yeah, use the background or the surface to stabilize the instruments.
That makes it a little bit easier then. I wanted to just go here.
Yeah, just put it there, and then we take our nail and then practice.
There we go. Okay, and then we have this one over here too.
Yeah.
Better view.
How do you hold it a little bit longer?
I'll hold it longer.
Yeah, you have more freedom to can move the needle.
Try to see how I can pick it up and curve it a little bit better.
Yeah, try. Yeah, every struggle you will benefit from the struggle, because now we're treating our hand, treating the muscle of our hand.
Do a backhand throw maybe.
Okay.
Not bad.
Yeah.
Wow, this is seeing the super microsurgery tools.
Yeah.
That is incredible.
Very cool.
When I watch this, I'm gonna wonder how much my hands were shaking watching this in a couple of weeks.
Okay. Yeah. Read the information.
This is a 9-0. We have blood vessel, PV, 100, and then it's the diameter.
Yeah.
5.1 millimeters is that for the needle itself. Yeah. It's tapered and it's 3/8 for the curvature.
Yeah. So to take the needle out, you see here is a scissor. Usually they would like to kind of cut here. Some of the suture, this ethicon suture is good. The sponge is not, the suture usually won't start in the sponge very firm. Some of the suture, the suture start deep into the sponge. If you take out the needle and then try to take the needle out like that, pulling it out, sometimes it starts there very bad, and then we pull the suture and damn it, and the suture will break from the needle. So we usually would like to release the tail first when there's nothing stuck in the sponge, and then we take the needle like that.
Got it.
And I think they draw a scissor here is tell us to just cut it.
Cut there, yeah.
and dangling the needle. That's the way. Right? We don't hold it too close to here, because now you can only move 1 millimeter, right? If we hold it here, we have 1 centimeter can move. That's the way to when we braid the suture. Yeah, so we dangling the needle, and then they touch the surface to stabilize it and then catch it.
And rotate.
Sometimes we can use one arm to push a little bit, making it kind of perpendicular to the needle holder. That's the stable way. Sometimes we pivot a little bit if the vessel didn't line up very well in front of us. So, and then also we may holding the needle backhand technique. Sometimes we holding the needle like this way. If the vessel in the worst scenario is from the lower right to the upper left, that's the worst scenario. It's really hard.
It's really hard to.
Yeah, because we cannot kind of turn our body to do surgery like that.
Yeah.
So we can holding the needle like this way. And now this stitching is like that. And pull the suture. See, I try to use one hand to pull the suture all the way out.
All the way out, yeah.
Yeah, and then tie knots. First knot we make a surgeon's knot.
And then you switch hands when you tie it, so you're not crossing your instruments. Is that correct?
Yeah, that's the why we pass the suture, so we can we can avoid have to cross the instrument. If we didn't pass the suture, to tie a square knot in this time, we didn't cross our instrument, we keep pulling it, it will become a slip knot, and then we have to cross the instrument.
Oh, and you want to avoid that, of course.
Yeah, so that's the point we pass the suture. If I pass the suture, this knot I just pulling it left to right, and then I make a square knot again, right?
And you're always doing square knots for microsurgery? Yeah,
most of the time we want a square knot. The reason we want a square knot is 2 things. When we suppose we use the suture to handling it, like pulling it or helping, used for our assistant to holding the suture to help us, we need to tie a square knot, or we will lose it, because if tie a slip knot and then as we pulling it a couple times, the knot get loose.
Yeah.
And another reason is, I think about the knot, if we didn't laying it flat, we keep pulling it, the knot actually will twist the edge.
Interesting. Okay.
I will show you. Yeah, I'm going to cut the suture.
Thank you. And then I'll put
That's it. We cross the instrument to lay knot flat. We don't want the knot twist the vessel. Like here, if I didn't pass the suture, tying the knot. See?
Oh, then it won't. Yeah.
If I keep pulling it, the knot will twist the edge of the vessel edge.
Oh, yes.
See that?
Yeah.
This force will kind of making the edge inside the knot is kind of twist.
Like a little torsion or torque force on there.
Yeah, that's the way. If we twist the edge, that's the way of force leaking, and also didn't smooth the edge, and the smoothest side it won't become smooth. So that's why we sometimes we even cross our instrument to make a flat knot.
Make it better that way.
Yeah. And as we pass the suture, there's 2 advantages. One is for the training, we don't have to think how to cross the sutures, because like if we, for me, I just naturally pulling the suture in the right way, but at the very beginning, I was confused. Oh, how should I pull
Which
the
way
knot?
would I go? Yeah.
Even I cross the instrument, so I don't need to think. Our brain is lazy. The brain don't want to think. Actually, just want to have fun.
I mean, it does simplify it. You have you're doing the same thing each time. You don't have to worry about which way am I gonna try to tie down this knot.
Yeah, and then the second reason is we train both our left hand and right hand to be able to tie knots instead of just keep using one hand.
More dexterity.
Yeah, I when I go to a talk of the professor talk about a microsurgery, he said he translated the technique from the regular stitching. A regular instrument, we use a needle holder. We put a stitch there and then holding the suture, and then use the needle holder to make loop and tie knots. He said we can just translate the same method, tie knots, and then take the suture out, and then use the forceps to hold the suture. That's the long end, and make loops on the needle holder and tie knots.
Yeah.
Yeah, I said, oh, that's not the same way I do. I do a little bit different. Then I realized my left hand and right hand. Sometimes if the right hand cannot go to this side because there's no enough space, I pass the suture and use my left hand. I didn't think there's too much different. And I come back to why I can do that is because when I was a resident, I see my teacher, he passed the suture, and then I feel that's fun. And then I pick it up, and sometimes I use that weight in my very beginning. And then ends up both on my left hand and right hand can tie knots. It's easy. It's not like writing. Writing is hard. Tying knots, left hand and right hand after we get used to it, it's very simple.
It's training muscles in the same motion. Yeah.
Yeah, it's way easier than like doing writing or even doing scissor. Scissor use the right hand is hard. Okay, yeah, time to cut the suture. Yeah, I'll give you the suture to you, and then you try. Okay, you can try whatever needle holder like this.
I'll try
this with the lock. You can try this one. Yeah.
I go grab further away.
Yeah.
Okay, so I'm happy with my positioning. Now, do you use your forceps to grab tissue, or do you just go straight in horizontally?
It doesn't matter. Now it doesn't matter. Now sometimes we stitch the vessel. We still use the forceps to pick up the adventitia to help us. Okay.
And for picking up the way, yeah.
Help you.
And then you said pull it all the way through.
Yeah.
So now that I'm at my edge.
Yeah, just keep try, and then I will share some tips for you.
Back up, I think I need more skills.
Yeah, up and down, and go the other way.
Go the other way, across. Oh yeah, that lays flatter.
Yeah.
And then I'm gonna switch hands. So
no, still holding the long end.
Still hold long end with here. And,
because the first knot we didn't recross the suture, so keep using this forceps holding the long end.
Okay.
Yeah, just keep going. Yeah, tie it down. I get it. I tie it like this way to demonstrate.
Oh, to visualize.
So let you see the knot.
Oh, I see what you mean now about tension. You only have so much before it rips.
Yeah, it's fine. Now you know how much stress you will bring the suture.
I learned my lesson. I wonder if I can.
That's the way of learning.
That's probably a little. Oh, I could get one, but a little too small.
Yeah, like this one you can use this. Yeah, try a little bit. See if you can tie one up.
Try to get as much. Do you recommend changing how you hold the needle driver? Because for me, I'm hitting my hand here. If I hold it like that, is that appropriate?
Nope.
No.
Yeah.
Just keep it here.
Yeah. Yeah. Now you can like holding the.
Even further back.
No. Close to the tip.
Close.
The more close the tip, you have better control.
The most control.
Like in the simple microsurgery, like Dr. Chen, sometimes he really holding it like just holding like a pen. I think about you writing your name.
Your most control.
Yeah, Kristof. You won't have any tremor unless you're signing a 1 million check.
Yeah. Right? Then I'd be having a tremor.
Like this, in this situation, because the forceps is smaller, so we would like to use the forceps to make loop job, so we can use shorter segment of the suture, right? If we holding this one and then the needle holder is big, it's hard to.
It's interfere.
Yeah, so that's some of the tips. Okay, I will show you something. Here I want you to remember. Let's move this one out a little bit. You can cut the suture.
Perfect.
Firstly, like pick up the needle. Like if we hold the needle holder like this way, because there's a curve of the needle. Before we close the needle holder, one arm already hit away.
Oh, you're pulling a little pulling it.
So in order to pick up the needle better, we turn the needle holder to match the curve of the needle. So we won't hit the needle away before we can close the needle holder, right? So this is one tips. Sometimes we try to use the forceps to pick it out but you can see the forceps is really tiny.
Yeah,
it's hard to catch the needle very good sometimes. So now the needle is on our left side, we use our left hand. If we still use our right hand, go to the left, it's not comfortable. So usually we pass the suture to our left hand, so we can pull it all the way out to the left. If we still use our right hand to pull it out, we want the suture. Think about this is the edge of the vessel. We want this suture pass through the vessel straight. We don't want the suture like coming out like this way. Then we're cutting, she's wiring the vessel. We tear the vessel.
So we want straight through.
We want straight. So we release the tail to make sure it's straight. If we go this way, we would like to put one arm up here to make it go straight. Right here. So this part is going straight out. Now in here, we would like to, there's two ways. One way is we pick up the suture directly by our needle hole forceps and then go tie knots. And this way we have to close our instrument for the first knot. For the first knot, we really don't want to close our instrument. So at the beginning, we pull the suture out, we bring it back to in front of us and catch the suture by the needle holder. Now this way, the first knot, it's very convenient. We don't need to close the instrument and tie a square knot. This is the way we can start. And then the second knot, we pass the suture and tie a knot. If we don't pass the suture, now if we already good, we can just go straight for the next knot. We bring here and make a loop. When we make loop, we bring the suture very close to the short end. So we make loop and then
so
catch
it's already down there. So you're
Yeah.
not traveling that much further distance with your.
Yeah, correct. Nice. Yeah. So if we stay here and make loop, and then we need to travel far to
You
here.
could lose it, yeah.
Yeah, so we bring here, make loop, and then pick up. That's the way of being efficient. And then second now, if we have to clock our instrument, usually you may see the teacher, they just pulling it up and down instead of completely clocks.
Mm-hmm.
And then the third knot, we can, if we didn't pass the suture, we can, if you go to the right direction, just left and right.
Yeah.
So, but in the training, we pass the suture. We want to train up both our hand, improve the dexterity of both our hand. So in the training, when we are still learning, pass the suture to train, practice both of our hand.
Mm-hmm.
So here I want you to remember two things. One is every time go back to in front of you.
Okay.
Not stay here and then make loops and bring it here. So every time go back to in front of you and very close to the, just right above the short end. Go back to in front of you.
And tie it right.
Yeah. Back to in front of you. Don't stay here and go grab the suture like this. That's making it like if you grab the suture like this way, see the suture is pointing this way, making it's really hard to make a loop. So bring it back to in front of you. Everything become natural, very easy. I don't understand this one until I teach. At the beginning, it's the same. I see you as me at the beginning, and I see the rest. And when they have struggle, I see myself. And even after a while, I getting better. I don't know what has been changed until I teach, and then I see, oh, that's why I was struggle, and then I compare to what I'm doing now, and then I understand that's some small difference, making me feel better now. So teaching is a little bit different from the surgery.
Teaching is a great way to learn too.
Yeah, and then when you're getting better, there's another way of tying knots. Like, see, I can control the short end.
Yep. And you're right. Oh, so you are really just above it. Wow.
Yeah. So this is the airborne method. Airborne method, we can let go the short end momentumly and then just picking it up. But the short end won't fall down and attach to the rest surface. Once it attaches to the rest surface, it's kind of it's hard to pick it up. Yeah. So this method is can make you more efficient, and it's also very very.
Oh my gosh, it's so efficient. Yeah.
Yeah, our resident, once they got this method, it will become their only method of tying knots.
I can see why. It makes a lot of sense.
Yeah, and then in some tough situation, like we walk in a deep surface, deep cavity, if we suppose once we lose this short end, it's really hard to pick it up. Sometimes the airborne, if you still will fly away, we won't be able to successful every time. So we can use this method. So now I can have, yeah, I won't lose any, both the long, either the long and
nice,
the short end. So this method we can control. So it looks slow, but it's more efficient instead of you have to find the short end after we lose it. So okay, right? Three knot, 100% be under control. Yeah. So usually this is 4 method of tying knots. Training method, the regular method we see in the OR, we don't pass the pulling it up and down. And then when you're getting better, practice the airborne. When you're getting to a tough situation, if you don't have a good assistant, or sometimes you only have one person, use the airborne second. Okay, yeah, try.
Okay.
Yeah. Try the simple one first. Now when we go to the OR, the best way to learn is being empty. Yeah. so see what the teacher do and then understand why.
The rationale for doing it.
Yeah, and what's the good thing of that method? What's the disadvantage of that method? And then pick up all the good things for you. And that's the way you become better than us.
But yeah, I agree with that. Try to see as many perspectives as you can and build your own from there.
Yeah. Yeah, you will build up your own method.
So come in, follow the curve.
Yeah.
And this angle, pull it. And
Yeah. Nice.
take this one all the way through.
Use your left hand to
Oh,
pull
use
it
my
out.
left hand pull it out. Okay.
Yeah, because it's on your left.
On my left hand side.
Yeah. And then when
start further away.
Yeah. If you want to avoid cross the instrument at the first knot, use the needle holder.
Oh, because I gotta pull this way. Yeah.
Yeah. Okay.
I'm actually coming.
Yeah. Bring it to the here.
Let me a little too much.
Yeah. Oh, here another thing I forgot. A number, 2/3. Oh no, 2.5 or 3 times. Holding the suture.
Yeah.
2.5 to 3 times of the short end.
Oh, long. Okay, so I should probably pull this through a little bit.
Yeah. So you can 2.5 to 3 times. That's the best length. You can make 2 loops, and then you don't have to pull it too far away.
As far. So I think this is about 2, maybe a little bit more than 2 times.
Yeah.
Over to it. So I have my first surgeon knot down. I locked my.
Yeah, bring it back to in front of you. Don't just let go.
Bring in front before turning.
Yeah. Okay. Try to make.
Being closer.
Yeah, the second knot, just 1 loop is good. Only the first one tie a certain snap. Yeah. You can point your needle holder pointing down. That's a little bit easier to pick up the suture.
Thank you.
Yeah. Nice.
We got there, and then I'm going to bring this back into view.
Yeah.
Create this side.
Now you see it's a little bit hard to make loops. No, it's good.
I can
the reason.
Oh, actually, yeah, I see what you mean. Come up, get that wing.
Yeah. Hold on. Yeah. Hold on. Still holding the suture.
Okay.
Now, what do you see the suture? The suture is under your needle holder.
Yes.
That's why it's hard to make a loop. Okay. Now, bring it back in front of you. Catch the suture. This way.
This way. Okay. Oh yes. Okay. Yeah.
Okay. Make loops.
I'm not.
Now you will see the suture is in front and above of your needle holder. Yeah, so once the suture behind under your needle holder, it's hard to make loops.
So bring this back again.
Back a little bit more. So now you can see. Okay, keep going. Yep. Yeah. Now you see it's a little bit weird.
So.
Yeah.
Oh.
So, yeah. What happened?
Yeah.
So that's the long end got looped into the nut.
Yeah. So let me start that over. So I was on.
Yeah. At the beginning, our brain don't have enough bandwidth to handle all the information. Okay. Yeah. Right.
Oh, this is straight up.
Yeah. Yeah, a little bit longer.
And nice.
Okay, now hold on. Now the full step position is important.
Okay.
Like if we put in here, it's out.
Over here.
Yeah, the knee forceps should be in between these two sutures.
Between the two.
So if it here is outside of two sutures.
Yes.
Yeah.
So I would loop it here.
Yeah, right, very close to the short end.
Very close to, and I'm not going to pull too much tension. Just get my knot down. So my knot is down. Bring this over. And then I'd be putting.
Yeah. So now you see the same
thing.
Yeah, holding the suture in front and above of the forceps. Yeah.
Okay. And then get close in between. Get it down.
Yeah.
There we go.
Yeah.
And
yeah.
Should be on this side.
Yeah.
Just my hand a little bit out of the way.
Yeah, awesome. Yeah, good.
There we go. It's coming there. I still have to perfect that or work on that area, but the motions at least are making a little bit more sense right now.
Yeah.
One more down.
Yeah. So two things to remember: bring it back to in front of you.
In front of me.
And then holding the suture in front and above of your instrument. The length is also important. 2.5 to 3 times of the stroke end.
Yeah. So 2.5, yep. Front. There we go.
Yeah, very cool.
Wow.
Yeah. So keep practice this method. Now I would like to share you another method of doing a stitching. Stitching of the in the microsurgery is understand a little bit more about why we doing that enough. Actually, it's translate from general practice.
Yeah.
Some of the technique we directly teach ideas from general practice. Some of the method we do slightly different in the microsurgery and general practice. Right after we put a stitch here, and we tie it.
Oh, so you bring it down that way?
Yeah.
It's like German.
Yeah, after we tie it, pour a suture, pour a needle, so you hand tie a knot.
So hand tie this?
Yeah. Yeah. So at the beginning, if we want to pay attention to tie a thread and square knot, okay. This one is if we go down like this way.
Oh, it'll twist.
Yeah.
Okay. So that should be.
So we probably will cross our hand. Yeah, cross our hand. In order to tie a thread knot in the
Oh, so it has to be kind of this way, maybe?
Yeah, still
that's
not
no
like
problem.
this way.
Yeah, can I see you, how you are able to?
Yeah, like in when I was in medical school, like learning the surgery at the beginning, we all like tie knots, tie knots everywhere.
Yeah.
In the pole of the bunk bag, in a water bottle, in the backpack. And usually we like karate chop or something. It's we tie knot to tie the first knot, we cross our hand.
So first knot crossed, okay.
Cross our hand. That's what we learned first knot, and then the second knot is kind of and go to handgun method. Then this one. So if we want to tie a square knot, we have to cross our hand at the beginning.
Okay, I didn't.
That's what we learned in the medical school. But when we go to the OR, the first thing I see in the OR is I see the teacher, because we really thinking about a lot how to tie a square knot, no slip knot. And when I go to the OR, the first thing I see is when the professor, they holding the suture, they naturally cross the suture.
Before, so they.
And then just go, and then they didn't tell, they didn't tell me when I was in the medical school. They didn't tell the medical student, but maybe they think, don't tell them too much, they have too much things to learn. But when I see they naturally just cross the suture at the beginning, so they don't need to cross their hand
afterwards. Yeah.
Afterwards, at the first knot, and then the second knot they just keep going instead of like us
alternating each time.
We pull a knot like that, and actually the knot still get loose. And remember, when we doing microsurgery, we pull the suture out, and then we pull the suture out to the left, and then we bring it back to in front of us, we holding our suture by the needle holder. And that's the same way of we cross our suture. By pulling the suture out, and then come back and use the needle holder to start. Instead of we pull the suture all the way out, and then we use the forceps, holding the suture, and then tie a knot, and then cross the instrument. So that's why under the microscope, cross the instrument, you will feel that's even harder.
Yeah.
So I slowly, at the beginning, I also kind of struggle left hand, right hand, but slowly I become most of the time like doing the same way of hand tying knots. I will cross the suture, so I don't have to cross my instrument to tie the first knot. The first knot is really important. When we're tying the first knot, in a real vessel, we want to raise the suture, use the suture to adjust the edge, so making it even. Think about if we have to cross our hand, we have no capacity of kind of adjust the edge anymore. So we just cross and tie it down. You don't have the ability to adjust the edge anymore. So the first knot, I feel that's a better way to do. And that's what I teach the students.
Teach it that way.
Yeah.
Seeing it on a more macro scale, actually hand tying it compared to just instrument tying microsurgical wise. Yeah. Really puts it more into perspective.
Yeah. Now in the OR, you may not see a lot of hand tie knots. Maybe in the orthopedics or in the general surgery, we still see hand tie knots. Most of the like in the vessel, we use a clip. But when there's no clip, hand tying knots, it's really one of the factor of how fast you can finish the surgery.
Of course, yeah.
Because you need to tie a knot of knots, like a tumor, general surgery, a tumor. When we need to dissect out a segment of the intestine or the rectal, we have to likely a lot of omentum vessel.
Well, so I crossed this one though.
So maybe, yeah, let's cross in and like when we cross, if we cross this one on the top, we use handgun. If we cross,
on the,
yeah, if we cross this one on the bottom, we use karate chop.
got it.
Yeah.
So I start with karate chops. I'm gonna cross.
Yeah, now you can cross the shooter first.
Sorry, on the bottom though. Oh, okay. Like, so like, okay, cross. This is on the bottom now.
And now you use the left hand.
Yes, left hand.
Left hand. Now you use handgun.
Okay, so this left hand stop,
Yeah.
handgun.
Yeah. See?
And it comes down nicely.
Yeah.
And karate chop.
Yeah, karate chop, and then this second knife you may not cross the hand and you're just pulling it up and down.
Just up and down.
Yeah, third knife
Karate
go
chop.
to the left to right again.
So this back. So everything. So if I tie with my left hand and I'm doing karate chop first, I go under, and then if I do handgun, I go over with my left.
Yeah. Actually, that's when we teach, we figure out that's the way. But when we're doing that, we don't really. It's kind of after we practice enough, it's just go like the muscle memory.
Yeah.
Just go.
No, this is very good to know, and hearing that thought process behind it.
Yeah.
Helps a lot.
Hey, you are right-handed, right?
I'm right-handed. I was taught to tie with my left hand though.
Oh.
I mean, I can. It'll take me longer, and I'm sure if I practice for a couple days, I can tie again with my right hand. I'm just more, yeah. So I can tie with both.
Yeah.
I prefer it as of right now, just more repetitions the other way.
Yeah.
Let's see. There we go.
Yeah.
Get a nice stick.
Yeah. So tying knots actually like there's this is a two-hand tie. There's another method is one-hand tie. One-hand tie usually is we handling something we have to holding it, like the tension. We want to tension it or not. Don't want it getting loose, so we use the one-hand tie. So what's that? This two-hand tie.
Whoa, that's what you just said was one.
This
hand.
One-hand tie.
Yeah, so you're looking at over thumb.
Yeah.
Yeah.
And so this method we can tie a surgeon's knot by
Going twice.
Twice. Then we can tie a surgeon's knot. And another way we can also tie a surgeon's knot by use two hand tie combined.
Oh.
Yeah, so this way we can tie a surgeon's knot.
Can you demonstrate that one more time? That was
just like handgun and karate chop
at the same time.
At the same time, so we can tie a surgeon's knot. Sometimes when there's some tension there, we want to tie a surgeon's knot
to maintain that tension.
Yeah. The karate chop, this hand is just a handgun method.
That is incredible seeing. One of those, I don't know if I can pull it out. I have to practice it a lot.
Absolutely, you can just kind of a lot of things. Even the microsurgery now, as I teach a lot, I feel that's just muscle training.
Yeah. And for the one-handed ties, I've not done one-handed ties in a long time. That was the first hand ties I initially learned, but
yeah. Sometimes I also lose the memory.
Yeah. I know the general gist of it. I got that down. It's fine, and then it's there we go. Okay.
Yeah.
I think in the OR it's always just two-handed ties rather than.
Sometimes they use a needle holder. use a needle holder to hold it.
Yeah.
Use the instrument time.
So I know, like, I know what I have to be working on now with my one-hand ties.
Yeah, you can get this.
Oh, really?
Yeah.
Thank you. This will be good. And then I have to find more time to come in and actually practice under the microscope.
Yeah.
But it's interesting seeing, looking here, hard to tell, and then you can see it. Our knots are right there.
Yeah. Yeah. So now you know at least now you know the method. Tying knots.
Yeah.
Tying knots. There's several different methods.
Mm-hmm.
Start from the simple method and train both our hand.
Yeah.
And then slowly, when you're getting better, you practice some method making you more efficient.
Mm-hmm. I think that's the biggest thing, just getting the skills down first and then improving efficiency over time to speed up the process while also.
Yeah, you have good hands. Yeah, you pick up everything I want you to teach you quickly.
I appreciate it. I mean, it helps having an incredible teacher, and these past 2 weeks at UW having all the attendings and residents guiding.
What I share is some small tips.
Mm-hmm.
These small tips sometimes is kind of a game changer.
Yeah.
If you don't know that, it's sometimes hard to make it. Have to struggle. 3 seconds.
Yep. That's awesome.
Yeah, I used to put my phone there, and then now I feel yes.
That's the perfect angle for it. Yep.
Yeah. Okay. Yeah. 2 hours.
Wow.
Yeah.
Time flat. That was 2 hours.
Yeah. It's every time it feels. Oh yeah. Let's talk to that.
Yeah, of course.
Thanks.
Should I bring the camera over?
So
the microphone camera.
Yeah, we don't have a professional setup.
It does the trick. It does the trick though. It does a good job.
Yeah.
Well, perfect. That was an incredible experience. Really happy to finally go under the microscope. I've heard incredible things this entire past couple weeks. Been looking forward to working with the true master. So I know I have a lot more skills to improve on, but learning the foundations and just learning about the microscope, I think it's put me in a good position going forward. I hope to look back on this in the next few months, next few years, and seeing how my skills have improved.
Yeah. So today, the goal is to help Kristof get the basic knowledge and skill to move forward. So we talk about a microscope. So I think now we understand the depths and eyepiece. So we want to, Kristof may now remember how to adjust the microscope to match the eyes, and also the depths, how we use the depths, going the higher power to make the microscope focus in the higher power. That's the way we get the profocal. Yeah, and then we practice some skill under the microscope. Oh yeah, we talk about the suture and instruments. There's a lot of small information there, and to understand that, we will be able to choose the right instrument and sutures. Yeah, and then we talk about different way of tying knots and how it translates from the general surgery hand tying knots. And it's interesting. We can translate from microsurgery and different area, and then go and helping us. What is the great one thing you feel is very helpful for you, like doing the tying knots and of this knowledge of today?
I think one of the biggest things is when we were talking about making things easier for yourself setting up, instead of trying to loop your knot further away, coming back onto the field to grab the tail, just bring everything to you. Makes a lot less, your more minute movements. You're not going to have to worry about anything slipping. No, just bring everything towards you. It makes your life a lot easier, and at the end of the day, efficiency that way.
Yeah.
Hopefully I can get to the point where I'm holding the knot straight up and just looping it around.
Yeah, you will.
That'll take a little bit more time, but once I can do that, then I've known I've mastered the basics of knot tying.
Okay, bring it to the like we kind of make the knot right above or very close to the short end. So we make a loop and catch it. Yeah. And anything else in your mind feeling, oh, that's good, very helpful.
I would say focusing on the transferable skills and learning just basic management. If you want to grab the needle, use the field around you, give yourself enough space. We're talking about the 1 to 2 to 3 ratio of suture that you need. I think that's a good thing for me to keep in mind, especially starting out. I was unsure of where I want to be grabbing from, and I think, again, as a beginner, it's okay to truly measure, all right, I'm here compared to here, because at first I was kind of more blindly grabbing, not knowing. I think I should, starting out, just to so I can get a better visual sense, I should be comparing, making sure I'm at that optimal distance on the suture length.
Yeah, the ratio of the suture can make us easier to make 1 loop or 2 loop, but don't have to go too far out of the field. Great. Yeah, it's good. You still have something kind of keeping in your mind. Sometimes after a while you may forget it, and then when you go to another practice, you pick it up again, and then that's the way of you encoding this knowledge deep to your long-term memory. And you can watch the video anytime when you feeling, oh, I forgot something. Okay, yeah. Everyone, our is 2-hour practice. We feel just like 40 minutes, and every time that's the way of we kind of feeling we enjoy the microsurgery. If you like our surgery, or if you want us to teach you in your country or in hospital, you can leave a comment. We go overseas to teach micro course. We go to Vietnam, Rwanda, South Africa. Yeah. If you reach out to us, we may show up in your